1999. From 1999 to 2007, he was a faculty at Rajas Dental College, Nagarkoil. And from 2000 to present, he is a faculty of DEMYSTIFYING College of Dental Science and Research, Trivandrum. And the year 2020, he was conferred with the FDS RCPS. And let me invite the senior most Orland maxillofacial surgeon, Dr. Varghese Mani, and who was the former principal of Mar Baselios Dental College, Kodamangalam. Sir, let me invite you to share your expertise with the participants. Sir, are you there, sir? Dr. Varghese Mani, sir?
Hello.
Dr. Suraj?
Yeah, Mani sir is there. Yeah, he is there. I think maybe you have to unmute him or no.
The host may unmute, sir.
Yes, Suraj, I am here.
Yeah, yes, sir. Good evening, sir.
Good evening, good evening.
So you can switch on your video also. It is off. Yes.
Okay.
Yes, sir.
Yeah. I will mute my this one because you are going to give a lecture, isn't it, Suraj?
Yes, sir.
Yeah, so I will unmute. Otherwise, it will be a very little disturbance. I will mute it.
You can give a small message or something now. It's an honor to have you here amongst us.
Okay, Suraj, all the best. I know Dr. Taha and we were together in the college, and it is a great thing that he has started this institution as one of the first institutions in the private sector. It is a congratulations, and I know that this institution is doing really well, and all the best wishes for this institution. Suraj, you are the head of the department there, and all the best to you, Suraj, as well.
Thank you, sir. Thank you. Dr. Rajesh, shall I start my lecture?
Please request the host to mute the participants. Mute and the video can be stopped.
Thank you, Dr. Rajesh, for a wonderful introduction. And thank you, Mani sir, for, with such a short notice, you are able to attend this lecture. I'm very honored to have you for my lecture. Respected Chairman, P.S. Taha sir, Principal, Vice Principal, the head of departments, faculties, delegates, and from various other places and practitioners, and my dear students. So when I was asked to give a talk, I just spoke with some of my colleagues. 1 minute. Can you hear? Yes. Yeah. Okay. So most of the practitioners, they are all very good in doing extractions and minor surgical procedures. All of them were excellent, and most of them actually were par excellence beyond maxillofacial surgeons because of their years of practice. But one dilemma still existed among them, the diagnostic dilemmas. And when not to do or not to do. There are so dilemmas in so many topics of minor surgeries, which are very common. So I would like to address some of the topics. It is beyond the scope of this webinar, to address all the problems, but I would like to address a couple of them, the basic necessities, right, which we encounter in maxillofacial surgeries. The changes are inevitable, like we came a long way from the crude technique of surgical to the modern era of robot. We are all proud to have dentists as persons who invent the local anesthesia as well as the general anesthesia, which is the backbone of all the surgical procedures nowadays. Now, systematic key, we all know that systematic approach is the key to a successful practice. Now, what is a systematic approach? Record keeping. Most of the practitioners are in a hurry. We always hesitate to document the records well. Nowadays, it is well essential because of medical litigations is becoming more common. So it's always better to have a proper data documented in your clinic. First of all, a patient comes to you with a medical problem. He reveals to you all the medical problems initially. Then maybe he turns back another 6 months or 1 year. So what do? He might not tell you all the medical problems because he is in the assumption that already I have told the doctor. Yes, he knows my medical problems. See, you may have seen hundreds of patients and it's not possible to remember all the history of the patients which you see. So it is always to have a document or a record so that you can go back and pick up all the medical problems which the patient had previously and then do the necessary investigation. And of course, documentation is essential for medical legal problems also. Informed consent. I would stress on this. Informed consent is necessary. Verbal consent was the line of practice earlier, but written consent, at least you should have a written consent. The modern era of video consent is into practice. Most of the corporate hospitals or major surgical procedures like transplantations, they take a video consent, which is more valuable. Well, at least have a medical or a written consent form, both in the native language, especially in the native language, which is most important. Medical conditions, again, it's beyond the scope of this lecture to address all the medical problems which we face, but I would like to stress on having the basic medical emergencies and equipments ready, or we should be prepared to face emergencies. Of course, you can buy a crash cart, something similar to this, which is easily available in the local markets and not very expensive. And most of the emergency drugs, whether you use it or not, you buy it and keep it. Even if the expiry date goes up, change it and keep a new one. Don't spend money for that. Forget losing that money because I have not used. You are lucky if you are not able to use that drug. Have a medical emergency crash cart. Have some more basic monitors. Nowadays, because of the COVID, all of you must be having a pulse oximeter at home. But do you have it in your clinic? Yes, have one in your clinic also. It's very useful. Then investigations. Again, this is where the practitioners or even surgeons and most of us, hesitate to go for a detailed investigation. We always are stingy in these matters. Blood investigations, there are the foremost is the coagulation profile. Have certain panels, a coagulation panel, renal panel, or a hepatic panel. Now, nowadays, literature supports that or reviews insist that the coagulation profile is almost necessary for all minor surgical procedures because of the incidence of unknown or the postoperative or intraoperative bleeding is much more because of undetected diseases. So if you have a basic profile of routine blood investigation including a coagulation profile, you might be able to recognize all these problems much earlier. Hepatic panel, those who suspect liver diseases have a hepatic panel because most of our drugs, local anesthesia, including analgesics and antibiotics, they all are metabolized in the liver. So if the hepatic or the liver is not fully functional, you can have postoperative or intraoperative complications can be occurred. Similarly, same is applicable to the renal panel also. Most of the anti-inflammatories are also metabolized, it's cleared through the kidneys. Another interesting fact which I noticed very recently, that especially in our department, we have noticed that we get around 10 to 15 patients with a history of allergy, multiple drug allergy. These are with a history of multiple allergy. There are lots of unknown cases. So with a suspected history of allergy, they will be bringing it to you with a test or a report, something similar to this. Now, what is the normal tendency? The normal tendency is to not to go through the above facts, but read the summary. We are all looking for shortcuts. So, reading the summary, here it is written, allergic to amoxicillin, ciprofloxacin. The second line, doubtful allergy to amoxicillin. Okay, doubtful. Doubtful means what? Well, I can give probably if it is essential. I would like to give. Okay, go back and read this. Infer this. I would always advise to infer this reading before going for the summary. Because here, in fact, allergy, it has shown as, 25 into 25. That is very large because the normal is, the control is 5 into 5. So 25 is 5 times. So it is highly allergic. So look at this ampicillin. It's 10 into 10. They say it's doubtful, but it's double the normal range. So more chance for anaphylactic reactions. So even doubtful allergy, in this particular case, I wouldn't advise any of these drugs. So always go read this and then come back to the conclusion. Normally, you don't get cases with a 25 to 25 allergic patients, but the range is usually around 12. About 12 is highly allergic. So 5 into 5 or somewhere below 8, I would recommend. And another fact is that here you can see lignocaine. Lignocaine is 7 into 7. Now, when you send for an allergic test, be specific because lignocaine, there are so many combinations of lignocaine. The general physician, the allergy test is done normally by a physician or a respiratory medicine people. So they are very familiar with plain lignocaine. When I mean plain, it means without any preservative. So we all know, we have studied during our undergraduate period that the reason for allergic reactions is the methyl paraben or the preservative, which is present in the lignocaine. So when you send, if you want to use a lignocaine with preservative, write specifically test with lignocaine with preservative or plain lignocaine. So here we cannot infer whether it is with the preservative or without preservative. So always confirm whether it's a plain lignocaine or not, and then proceed. Then there are some special investigation because we are very familiar with bronch or bisphosphonate-induced osteonecrosis of the jaws. Now the terminologies have changed because it's not only bisphosphonate which causes necrosis. There are so many other medicines which can cause necrosis of the jaw, and even certain other drugs, not medically related, that is MRology, and then we have anti-resorptive drug related osteonecrosis. Then we have come across certain unknown reasons for osteonecrosis of the jaws. So how do you check for that? The CTH test. CTH test is very important. You suspect a patient of such a medically related therapy, go for a CTH value. CTH value less than 150, surgery is performed with minimal risk. So it should be above 150, you can do a SAVE. That means the bone turnover, the osteoblastic turnover is much more. If it is less than 100, don't touch. Take a drug holiday with the advice of the concerned physician. Send back the patient, take the advice of the concerned physician. If possible, give a drug holiday, discontinue the drug, give a holiday, let the osteoblast come back in activity. And between 100 and 150, probably you can do. And above 150 is desirable. Next comes the under investigation procedure is the radiographs. Well, we all routinely take an IOP. Okay, IOP is good to isolate a particular condition. It's like a horse's vision. You are looking into one area. OPG, you have the facility, or if possible, I would advise you take an OPG because you might find out or hidden pathologies can be made out, or early detections can be done with a single radiographs. Then occlusal, certain other radio, not a common practice nowadays, but occlusal is very useful in detecting one mandibular fractures as well, especially anterior area, and as well as for detecting any submandibular calculi. Now look at this. Will OPG be sufficient? Sometimes we might have to go for other radiographs also, because OPG, we are actually assessing conditions with the 2D radiographs, not a 3D. So 2D means you need another radiograph to support you to make it have a 3D view. So in this case, you can see the first molar on the left side was extracted because of continuous pain on the left side of the maxilla. Suspecting the dental problem, the tooth was extracted off, but the pain still continued. And what we did was we took a PNS view, and you can see the whole sinus is radio opaque. So the actual problem was lying in the sinus, which was radiating into the tooth. So sometimes we need to have multiple radiographs to assess. Now you go back and see the OPG, then you might see that there's a slight radio opacity which you did not detect earlier. So always, if you suspect something, you go for a second kind of radiograph in a different angle. CBCT is a gold standard nowadays among dentists. Well, it gives you beautiful pictures, especially the bone. Soft tissues, probably you have to rely on other radiographs. And CBCT, with the software available, you can have a lot of fun turning around the skull, viewing it at different angles. The surgeon loves it when you get a scan like this with 3D. We can go into, go behind, go from top, etc. But we always love CT scan. So some cases is beyond the CBCT. So we might have to take a CT scan for more precise valuation. Decision making. Well, decision making, there are a lot of confusion. One is the preoperative angle. Should we give or not? Pain control, the type of anesthesia, and intraoperative pain or postoperative pain control. Then the common one, third molars, to extract or not to extract. And finally, some lesions, the diagnostic and prognostic dilemmas. And of course, complications. Then their prompt management. It's always better to avoid the complications rather than having complications and managing them. Now, the problem one, preoperative antibiotics, essential. In the literatures, there are two schools of thoughts, and one says that literatures, the interesting fact is that a survey was conducted, and it was found out that the 10% of the antibiotics prescription was from the dental community. That is, some say that we are misusing the use of antibiotics. You give antibiotics unnecessarily, it will got some drug resistance, etc. But there's another school of thought saying that preoperative antibiotics reduce lots of post-extraction bacteria. So, reading literatures is again confusing. So, what I would always depend on, or the decision, I make the decision seeing the particular condition. You see, there is chances of infection. Infection is present, or mild infection, or history of recent infections. I would definitely give antibiotics. One, not that I'm afraid of a post-operative sequelae. Intraoperative getting anesthesia, especially for extraction, in an infected case is, and most of you have experienced that it is not an easy way. You will be giving multiple injections. Even then, you touch the tooth, it's like a hot tooth. The patient will jump up. In order to avoid that, you always better have a broad spectrum antibiotics, and along with an infected tooth, give an anaerobic coverage. An infected tooth, infection is inside the bone, is an anaerobism. So always have a coverage for that. Metrogyl is sufficient enough. So good broad spectrum, probably amoxicillin or a penicillin derivative, and anaerobic coverage metrogyl should be sufficient for most of the cases. So finally, we have to decide whether to give or not, depending on our experience and on the particular condition of the tooth. Local anesthesia, it's the backbone of dentistry. Not only with the backbone, now for most of the surgical procedures which is being undertaken, especially the facial, cosmetic, minor surgical procedures are being undertaken under local anesthesia. Now, topical anesthesia. We are all familiar with topical anesthesia, but if I take a polling, there will be less than 50% of the population which uses the topical. anesthesia. Why? Maybe we are impatient. We don't have time, or we feel that we don't have time to sit and apply, wait, talk to the patient, and then go for an injection, but I would advise you to use a topical. Topicals can be in the spray form, solutions, gel. Now, again, the dilemma occurs to you whether to use ointments or gels or solutions. I would prefer gels because the concentration is much more and it's very effective, and you can apply it for a topical. Sprays, you will get 15% concentration sprays are available. But sprays, the localized area, especially you are going for a palatal injection, you spray it in the palate, the whole thing the patient swallows and the whole pharynx get anesthetized. And what happens? You probably he'll have a lot of gagging sensations. So in order to prevent that, it's always better to use a topical. There have been literature supporting the use of gels over sprays. Now gel, well, we all take a cotton and take a swab or something like that and keep it there. No. Have a nice eye, something like of this sort, a earbud. Take the minimal quantity, by that you will not be wasting too much of the local anesthetic material also, and apply it where you have to get. See, first of all, you have to keep in mind that you cannot extract a tooth with a topical anesthetic. It gives only the mucosa. The depth of penetration is very minimal. The actual penetration of an injection depends on your needle. As far the needle goes inside or reaches the periosteum of the bone, that is when it is very painful. So first give a topical anesthetic gel, wait for a couple of minutes, and then you inject. When you inject, make sure that you don't insert your needle fully. You inject just the submucosa where it has been anesthetized, give a little bit of topical, and wait for a couple of seconds and then proceed in it. As you proceed, you can inject and actually proceed. It's a kind of infiltration, whether it's an infiltration or even if it is a block. As you insert the needle, slowly give and give. But this is not very practical in giving a blocks, because we are always afraid of injecting into the vessel, because unless we aspirate, we are not very happy. But infiltration, I feel, if you give it in the into the vestibular area, you don't have to be afraid of any major vessel coming across that. Recently, ice. We all know that after eating ice cream, it's always funny to hear people speak after a mouthful of ice cream in their mouth, and the whole area gets numb very fast. So why not use ice? Yes, it has been described. Literatures are there. And recently, we also have started a study in our department using ice as a topical anesthetic. We're comparing it with other local applications also. And it is very easy to make and very cheap. Nasal sprays are available. The use of nasal sprays are very limited among dentistry. But see, anterior maxillary tooth extraction, infected tooth, or where there is an abscess or a cyst extending up to the nasal floor. This is quite useful because anesthesia of the nasal floor is very difficult through an intraoral approach. So always you can have a nasal spray and anesthetize that area, and then you can proceed with any sustained manipulations. Then selecting the right needle. Well, we all use either of this needle. I prefer this long needle with the 26 because it's very thin, and the thinner the needle, more fine and less painful. The thick needle, well, you can use it maybe after this injection if you want to give some periodontal ligamental injections or intra-bony or intra-pulpal injections, or you can use a thicker needle, but try to use a thin needle always. And when you talk about thin needles, insulin syringes, that is the best choice. You give it, but the disadvantage is it's a very short needle and you cannot give blocks or infiltration there. So first, after topical, you give a small injection with maybe 1 cc with using this insulin needle, and then you can change it to a normal gauge needles. Different sizes are there, and you can choose among it's all color coded. Recently, there have been described very recent techniques of anesthesia, and one is the conscious sedation. As you can see here, this is a funny feature, not of a real conscious sedation procedure, but conscious sedation is quite useful, and we have been trying it in our department, and now I feel like using it more often nowadays. And Vibra, there are other instruments or described in literature also. But Vibrajet is one instrument which actually works with the principle of vibration or the gate control theory, where one sensation blocks the other. So the pain sensations are actually blocked by the use of this vibration. You can attach the syringe, and we have done a study in our department, and our chairman is very familiar because a couple of years back, he brought it from his from abroad and asked me to do a study on this and give a report. And if I found it very useful, and patients, especially palatal injections, patients literally complained of pseudo pain. I tell you, we have done a study on more than 100 patients cases, and more than 90% or 98%, they complained of pseudo pain in a VAS scale of pseudo pain. Okay, we can try using, or we can use other equipments also which are in the market. Now, the next step is the local anesthetic. Lignocaine, that is the only drug which we are familiar. Why not use some other drugs? Why not use articaine? Why not use the newer varieties? Well, we are all afraid for changes. Make a change, because some are very effective. We have done a study with articaine and lignocaine. There is no significant change related to the medical problems. Articaine is supposed to have some effect on the cardiovascular system, but from our experience, which is very limited in a study, we did not find any hazardous changes. So probably because it's 4%, it is more effective. You can change it from a 2% lignocaine to 4% articaine also. And another one is ropivacaine. Ropivacaine, the advantage is it's got a self-vasoconstrictor property, even without the presence of, because adrenaline is a beautiful drug which helps us in our extraction procedures, which reduces the post-operative bleeding. You find the socket bleeding, you take a local and inject, or you can use adrenaline directly also. So vasoconstrictors are the favorites of all surgeons or all dentists. So why not use ropivacaine? It has got a vasoconstrictor property also. It reduces for major surgeries where you feel that the bleeding will be more. You can use these kinds of drugs. This is quite valuable because especially for surgical procedures which requires bone removal. You use bone removal means lots of edema. You use a micromotor or any kind of instrument to remove bone, there will be edema. So in order to reduce edema, surgeons are very fond of giving dexamethasone injection. So, that's the disadvantage is 2 injections. Then after the procedure, either intravenous or intramuscular. There are a lot of other options also, which I will be talking later. But you can have a twin mix. There is another investigation is going on. It's one of the part of this work, one of the postgraduates. You take 2 cc or 1 cc or 1.5 cc of lignocaine, and then add this dexamethasone 1 ml along with that, and directly give a block or injection. No harm. It's very effective. Reduces the postoperative edema also. And this is much easier and can be done by any practitioners if you're not very familiar in giving an intravenous or intramuscular injection. Where to give? I still have this confusion in inferior alveolar nerve block, but I'll be talking about that later. Now we'll go for infiltration. The conventional technique is, you always go in the textbooks, go parallel to the tooth. Well, I would change it a little, maybe by experience, and there have been literatures also supporting that, but make it a degree of 45-degree angulation. That to avoid complication, especially lower upper anterior tooth in an elderly patient where there has been lots of resorption, or in a resorptive edentulous area, we want to do some alveoloplasty. You inject, unless you have an idea of the bone available, you will be accidentally going into the nasal mucosa. And I have seen the fresh third years or undergraduates, when they give the first injection, blood coming out through the nose. This is because of the accidental injury to the nasal mucosa. In order to avoid that, angulate it 45 degrees and don't go so high up. Just above the attached gingiva, inject it. Less pain, is very less painful. Start injecting, you can see the mucosa getting burnt. You can see it getting ballooned. There was an article in an endodontic journal called a piggyback technique. That is, you inject like this for an anterior tooth and then compress it, that actually goes into the diffuses into the palate. I mean, it's only literature supported. I don't have experience with that. And they say that they don't have to give a palatal infiltration. Maybe it will be good for endodontic therapy also. So try to give this, you'll be avoiding lots of complication. And another complication when you give posteriorly into the vestibule, making it parallel to the tooth is that it might go into the soft tissues and can cause facial palsy, temporary facial palsy. All these things can be there. And lower also say vestibule you give, and lingual. This is very important. Lingual, you retract the tongue fully along with the floor of mouth, because I've seen people giving into the floor of mouth just beside the submandibular duct, and it is very, very painful if you have experienced that. So give it into the gingiva along the pore, slightly below the pocket, gingival pocket, and there you can see the solution getting into the superior stem. And I'll tell you, it will act immediately, within minutes, not even minutes, less than a minute. You can do even a premolar extraction, you inject and then wait for 30 seconds and then you can inject. But I wouldn't advise that. Always wait for 2 or 3 minutes so that the patient is comfortable. Palatal, same. Don't give along the rugate, slightly give below. Here it is different. Don't give along, near to the tooth. Go away from the tooth, where this area is much softer. Because if you give it more towards the tooth, the periosteum is so firmly attached that when you inject, you find it very difficult to deposit the solution. So slightly go away somewhere around this. And palatal injections more like somewhere around like this. The bone, the periosteum is slightly soft and slightly detachable, and you can inject it much easily. Blocks, I told you, I still have trouble in giving a proper inferior alveolar block. There are a lot of studies and literatures. The conventional technique is to give a block with around somewhere else, but I've seen most of the people give a block in this area. Now, maybe it is more effective because it's something like a mandibular nerve block. It's not called as an inferior alveolar. You're giving at a higher level, and that might probably give a block to mandibular nerve. But the post-operative discomfort is much more in giving injection this side, because the muscle bulk is more. You are actually the medial pterygoid. You are puncturing the medial pterygoid. You're going and to a certain depth, and that will cause post-operative lots of trismus. So if you encounter trismus after an inferior alveolar nerve block, probably you have to change your technique, bring it much lower down. Literatures have shown, and we also have done a study in our department, a CT scan study, and we found that it's against some of the literatures that the inferior alveolar canal is actually foramen in our population is much below the occlusal level. So why give high? Why not give at the occlusal level? Standard, that would be sufficient, because we have found out that in a study of 100 cases, but that is not sufficient to come to a conclusion. But practically also, it was very effective from my part in the giving at a level of the occlusal, and that will also produce less complications. Selection of instruments. We have a set of instruments which we bought when the clinic was new, and probably most of the clinic we might be still using it. Change your instruments, and don't keep all instruments in your tray for a surgery. Keep only the necessary instrument. All you need for a minor surgery, for example, as an impaction, is a BP handle or blade, periosteal elevators, maybe 1 or 2 kinds, different for retraction also, and an elevator, a good one and a convenient one, not the bulky one as we often encounter. Have a full smooth, go select a good instrument, or you can order it online also. You get lots of good instruments nowadays available online. When I say good instruments, it's time to change these kinds of suctions and suction tips. Suction tip, it is all worn out. These will injure the mucosa. So I try to avoid that, have good instruments, have good kind of force. And always, you keep changing. Why not try this American forceps? American forceps are very good. I mean, I find it very comfortable to extract the lower molars and lower third molars, especially when the mouth opening is limited. It will not cause any tissue damage to the angle of mouth. You don't have to stretch your corner of the mouth, etc. Okay. And some luxators, well, I was not very fond of this luxators until very recently when one of my periodontists actually demonstrated this in extracting. Maybe surgeons don't have the patience to use this kind of luxators. You need a lot of patience, but I tell you, it is fantastic. It's less traumatic. I mean, less traumatic and very comfortable to the patient also. Physics forceps. Well, I've been hearing it for a long time. I have seen a couple of demonstrations. It actually works on the principles of a bottle opener. Bottle opener. Just put a video on this. You can see, you engage it, you have a pressure, and then slowly take your time, and then you can see the tooth getting luxated and the tooth moving or popping out of the socket. This is practically possible, but with experience, but you need some experience with it. So you can use this kind of forceps also to luxate the tooth and take it out, causing less trauma and discomfort to the patients also. But the only problem is it's quite a little bit expensive. Then we have other techniques of, this is something new which we haven't tried out yet. It's a Bennett's tunnel, something like the action is basically of a pulley. I have a pulley system. What you do is you elevate the tissues and the gums around sufficient enough, and then make a drill into the tooth so that you can engage a locking device and introduce the locking device which is engaged into the tooth, something like an implant. You turn it and it fits there. Now you attach the pulley system. And with this, you can actually see the string is attached, and by turning, this pulley works, and tooth is actually luxated. This is possible for maybe not practical for multi-rooted teeth, but for single-rooted tooth, this is a good choice also. Latest one, sonic instruments for bone surgery, widely something similar to a piezoelectric. It's good for implant procedures and implant surgeries, where especially for the socket shield technique, where you can split the tooth and remove the piece. But like I said, you need a lot of patience using the sonic device and allowing it to luxate. It doesn't take the tooth out. It actually luxates the tooth and allows you to be picked up with a forceps or any other instrument much faster. But you need a lot of patience to take this. And finally, once it's luxated, you can use a forceps to extract it out. Endoscopically, yes, this is good. When I said about, when I mentioned about socket shield technique, where you want only a single shelf, it is practically, possible, but quite difficult. It's only by assumption that we leave a portion, only the buccal part of the root behind for an implant procedure. But with the help of an endoscope, you can actually go to the root apex and see if all the hemi section of the tooth has come out, and we have only the buccal shelf remaining. Another problem encountered among practitioners is the premolar extractions. Most of them say that when I extract a premolar, I always end up in this kind of root fractures, especially multi-rooted teeth. You might even get three-rooted premolars also. So I don't give a standard buccal and lingual tractions. I've not read in any of the textbooks or literatures regarding this technique, nor I have published this, but most of my students or most of you have passed out from PMS college are very familiar with premolar extraction. I am sure they will do a premolar extraction without any hassle. This is how we do. It takes few time and it needs some experience, and if you have an experience, you can actually literally finish it off in 10 seconds. You can actually see, if you look carefully, the tooth popping out by this rotation technique. 1, 2, 3, it should pop out. See, it popped out. So literally you give a rotation. Even upper premolar also you can give a rotation, but you should know the limit of rotation. Don't give too. So it takes time, but 90% or 99% the root doesn't fracture. Not only for the mandible, even for the maxilla, even if it is a one. Now what happens if the root fractures? Well, orthodontist doesn't want you to do an open method, remove all the bone. Here comes my periodontist advice. Have a peritome. Use the peritome. See, the peritome, what is the principle? It actually, this fine knife-like edge, it creates a space between the root and the bone. So the aim is not to just dig it out. Trying to create a point of application or remove space by this literally compacts the bone against the other tooth and wall and all around the tooth. And literally, once the tooth is created, you can use a coupe lens or any kind of elevator, and the tooth will, again, you can see the tooth popping out or coming out of the socket much easier. As you can see, the buccal cortex, though very thin, is very intact. Good for the orthodontist. Impacted lower third molars to extract and not to extract. Some people will agree in extraction and some will not agree. There are two schools of thoughts. The American Association says, yes, you remove all tooth because some point of time it is going to create problems. Whereas the British National Institute of Clinical, they say there is no practical evidence. So removal of third molars or pathology-free third molars. Now the question is, should we extract once a big pathology has occurred, or is 6 months screening practically possible in our nation? So again, there's a controversy regarding the removal of tooth, but you can use certain guidelines, and especially among our populations, depending on this is the Dodson's guidelines, and depending on the symptoms or the disease present, symptoms present. And we can group into A, B, C, and then about the clinical evaluations, depending on the periodontal depth of the adjacent tooth, damage to the adjacent tooth, etc., and also radiography. And each clinician, I feel, should decide whether to remove or not. In my opinion, a tooth which is you feel that is not going to erupt into the oral cavity by its angulation and by its lack of space, and beyond its chronological age, maybe 24, 25, or 26, it's always, I would advise to extract the tooth, because some point of time it may or may not create problems. So it's always, it depends on, again, individual preference. Now, before going for an impaction, you always hesitate. We all are familiar with these war lines, this white line, amber line, and this red line. And of course, you draw anyway. Get an IUPA, you roughly draw this line. Initially, you might trace it, or you can have imaginary lines when you view an X-ray, something like this. So that will give you an assessment of how far the root is away from the inferior alveolar canal, how much deep the impaction is. This is the amber line from the crest to the anterior bottom ramus, and how far down from the occlusal plane. So it's always better to assess any radiograph, something like this. And the choice of bone removal. Once you have decided to remove, I'll be talking on the choice of bone removal and incision. So bone removal depends. There are a lot of techniques described, but the common one is the Moore angle base, the guttering technique using the micromotor. Chisel mallet was the favorite of our ancestors. And but though it causes less edema, I would make this more traumatic to the patient. You having a chisel and banging it, the patients might not be very comfortable with that. So I would prefer either a micromotor or very recently laser, hard tissue laser and piezo. They are excellent, but as I said, you need a lot of patience. Good for the patient, good for the bone, good for the surgeon with less complications, but if you are patient enough. So micromotor standard practice, like I said, hard tissue lasers, we have done a comparative study with burr and lasers, and we have found out that the hard tissue laser, there is less postoperative edema, discomfort, and trismus to the patient when compared to the micromotor group. And as you can see, this is with the hard tissue laser, how neat the bone cut is with minimal bleeding. You can see the natural blood. It looks very nice. Piezo is also equally effective. Recently, our postgraduate won the best paper award for presenting this comparative study between the piezo technique and the burr technique. Incision, numerous incisions, depends on the commonly used is a Watt's incision, somewhat like this. You give a ring here, and it's always better to give a modified Watt because you will try to preserve this papilla. Because in order to avoid distal pocket formation after impaction, which is very important, is to have this papilla. Whereas you give a releasing like this, you are putting the tissues in. So have a different, have this papilla intact and re-suture it back. But I prefer not to give a releasing, something like an S-shaped incision, which is effective in my hands. But sometimes, deep impaction, you might have, if you want more exposure, you might have to give a relieving incision. The key of incision, most of us make a mistake in angulating the blade. So this is how the papilla is being separated. Periodontists are very familiar with this kind of incisions because they always like to have the papilla in their hands. And so go into the dental space, angulate it, curve it down and incise and walk around the tooth into the pocket. And that is how you should do. Keep walking around the tooth up to the distal area. And then probably you can give a distal incision. Incisions need not be very lengthy. It should be very, very minimal. Very minimal distal incision is required to have a good exposure. So once you put the incision, raise the flap from the crest and lower it down. This is sufficient. Don't raise a big flap. Stripping the periosteum causes lots of edema. So avoid stripping. That is most important. This is a comparison between the S-shape and with the relieving one. Relieving one also, don't give a big relieving. Give a small one which is enough to reflect this flap. Why do you want to give a big relieving incision? Expose the whole bone and unnecessarily cause postoperative edema. So once this is elevated, again stripping down buccally, stop it there because you are not going to remove this bone. You are going to only gutter, keeping the buccal plate, you are going to remove bone around the tooth, not removing the whole buccal plate of bone. That is called the guttering technique. By elevation, earlier I never believed this, that there was a retromolar artery present. It's a branch of inferior alveolar artery. I mean, recently I came across when I saw it myself. Usually we encounter bleeding when you elevate the flap distally, and most of the time it stops on its own. Maybe it's a small vessel, but always be careful. You can have large vessels like this also. So when you elevate the flap, look for this artery around. If there's no artery, good. Don't elevate too far. Elevate as is required to remove bone. There have been studies, and study still going on in our department on cadaveric mandible, on the prevalence of their retromolar foramen, and the incidence is more. We have come across lots of foramens, as you can see. Next is the protection of the lingual cortex or the lingual plate or the lingual nerve. Postoperative lingual nerve paresthesia is one common complication. So such a tooth, you need to remove a lot of bone here, keeping the lingual plate intact. So always it will be best to protect the lingual nerve by elevating subperiosteally and keeping a periosteal elevated there so that the accidental slippage of burr will not damage your lingual tissues or the lingual nerve. See, as you can see, it's well protected. Now you can remove. Bone removal should be only this much, 1 bed depth and not too far, close to the tooth. This is sufficient enough for the tooth to get luxated. Tooth splitting. Tooth splitting is another art. Various articles have described various kinds of tooth splitting. Depends on the kind of invention. Basic idea is to remove the lock which prevents you from your elevation, whether it's a horizontal. And another mistake people make is the splitting of the tooth. If you're not in the correct angulation, you will end up in a wrong split. You'll be splitting either the along with the roots, the crown alone cannot be split off. So angulate the burr, something like this. Say, go behind the patient. If it is on the right side, if there is a 4-8 tooth extraction, go behind the patient, angulate the burr, something like this. Make sure to protect your lips and the buccal mucosa with some sort of retractors or instrument, and then start cutting. You will get a beautiful cut like this. You can easily cut the tooth and a portion of the crown. Only the lock need to be removed. You don't have to remove this mid-enamel junction. Leave a portion of the crown so that you can have sufficient bulk to elevate the tooth out. Quadrangular handpieces are quite comfortable in splitting the tooth and removing, though we don't very commonly use it. I would advise you to try this quadrangular handpiece with some TC burrs. Very effective, especially for cutting the tooth. Once the tooth is extracted, again, should we fill the socket or not? Well, it is not really necessary because 90% we don't fill the socket, but try it. We can fill it, especially for the if not for the third molar, for other teeth. Try that because we are preserving bone. We are allowing the bone to heal faster. Implant placement can be done if there is sufficient bone. Or if you don't fill it also, it will heal, but it might take much longer period. Then we have various materials available in the market. Gelatam is one good antibacterial and a hemostatic. It has got two advantages. It's got an antibacterial, it's a hemostatic, as well as it got acts as a filler material. It's very effective, especially for premolar extractions used to it, not only to control the bleeding, but it favors a faster healing. Also, collagen plugs are there, collagen membranes are available. You can try one of the PRP. We have actually done a research on this PRP, comparative study with and without PRP, and it is published in the American Journal of Maxillofacial Surgery also. Very effective. Bone formation is much faster. We have taken postoperative grid X-rays and it had proved a much faster bone formation compared to the control group, which we did not keep anything. Placement of drain. There are something available as intraoral drains, which you can keep it after impaction. You feel that, there might be slight ooze. You don't want the hematoma to be collected there, or you want to reduce edema. Edema usually occurs in a closed area. You keep a drain, all the edematous fluid will flow. But, some patients might not accept this. So it depends. You feel that it is essential, you can try using a drain also. And closure, normally with silk, this is without the anterior relieving incision, and this is with the anterior relieving incision. You can use tissue glues. Tissue glues are available nowadays. The orthopedicians and other specialties are very fond of this tissue glues and bone glues also, and bone cements. Why not use tissue glue? Intraoral tissue glues are available, and this is after an impaction thermal extraction. We have used a tissue glue, good healing. It doesn't give away very easily, and less traumatic for the patient also. I mean, he doesn't have the irritation of a suture sitting inside. Suture material, silk is a standard. Have a good quality silk. There are lots of silks available in the market. Most of them are like a hair. It comes out in pieces. Get a good material or an expensive one. And you can use the resorbable or non-resorbable materials available in the market. Whatever you do, the healing, whether it is a resorbable or non-resorbable, in the ancient time, all of you, some of you might have seen this movie, Apocalypse. I think it is, so I forgot the movie name. Okay. they have used ants. It was ancient. They have used this ants and they put it there, and the beak is broken off. That has been used, something like a stapler effect for suturing wounds. Now, the earlier dilemma, whether to extract tooth or not, my experience, I would advise to do, because I have come across cases where something like this, unidentified, you don't want the tooth which is sitting here to be pushed to the coronoid region and making it difficult and losing all your teeth. You don't know when this will happen. This might not happen to all patients, but do you want this to happen? How do you know whether this patient category belongs to this or not? I have come across tooth being pushed down into the lower border where you have to go for an extraoral approach to remove the tooth. And maybe for 90, this is a 92-year-old patient, a denture wearer for 30 years. He didn't have any problem. So people would have said there was a canine tooth impacted which was unidentified, and he was unaware of this. And he came with a complaint of ulceration in the mucosa, and radiographs and the CT revealed a canine tooth impact. And I don't want to do, I really attempted it, but I really don't want to do it in my practice to attempt an extraction in a 92-year-old man with a very thin mandible. But sometimes we have to do it. So you see an impacted tooth nowadays, because of my experience, I would always, if it's not coming to the oral cavity, I would advise you to take it off. I don't want the patient to come back after 10 years with a problem like this. And elderly patient, when you go for an extraction, when symptoms arises, deep impactions can result. The impaction was taken out very nicely. Well, if you haven't noticed, can you see a small line here, very thin faded line, which was asymptomatic. And 3 months back, the patient came back, he had a mandibular fracture. Probably he had a mild crack or a mild minute green stick fracture at that particular time, which progressed. And we had to go for an open reduction later. So we don't want such complications to happen. So young age bone will be very resilient, elastic, and such complications can be avoided. Next comes maxillary third molar extractions. The common complication which arises is the tuberosity fracture. How to avoid that? Use the cryos. Cryos elevator is a good one, but you have to see it's a 45-degree angulation. You keep it, engage it, something like that. Support the adjacent tooth also. Don't give leverage on the tooth. Engage it far deep below the cervical area into the intestinal space. And you, in fact, don't push it distally. You rotate it down. Rotate or you curve it down. This you can probably avoid tuberosity fracture. Something like this can be avoided. We don't want this to happen. And another important fact is that distal periosteal elevation. Because of the inaccessible area, we normally tend not to elevate the distal area. If you can reach that area and elevate that periosteum, then probably you will not encounter such complications. If the perineum is attached, imagine you pull the tooth out, the whole soft palate or the palatal area gets torn off and heavy bleeding might occur. Avoid that. And one good instrument, this case of an impacted maxillary molar, you can use it for any third molar extraction, is the elastis retractor. This retractor is very comfortable. You engage it, keep it, and it gets locked into the tuberosity area. It stays there. And you can see the tooth and you can elevate it up. There are different advantages to this. One is it prevents the slippage of the tooth into the infratemporal space or into other soft tissue area space. Second thing, it also prevents the fracture of the tuberosity or the pterygoid plates. But because excessive force, you'll be able to feel on your left hand where you are holding the elevator, and probably you can change your direction and elevator. This will not allow any distal movement. It will allow only the tooth to come out in a sweeping or a rotatory motion. Now we have finished the third molars and lower molars and canine impactions. Do we have to remove all canine? No. You consult with your orthodontist. Ask him whether we can see this tooth. It's only because canine, for smile designing, canine tooth is very important. So the prosthetic and the restorative people are very fond of this tooth and they want it alive. So try to save it. You expose. Discuss with the orthodontist and you can pull it down. Basic technique is to design a nice clavicular flap, raise the sufficient amount, Elevate subperiosteally. That is the key of less bleeding. You should see bare bone like this, not red bone. Make sure that you see bare bone from the crust. Then it will be there will be less bleeding, and the orthodontist will find it very easy to attach his bracket and then close the tissue over that, and he can later on pull it out, which he has anchored into the wires. And some tooths, it is inevitable, you have to remove it, and horizontally impacted tooth. So minimal bone removal is the key. Maxilla bone is soft, don't remove too much bone. Again, cancellous bone will bleed. So expose the tooth out, section the tooth. And what you can do is, what I do is make a hole into the canine tooth, especially in the enamel area. Enamel is much stronger than the dentin. Enamel area, and you can use some sort of instrument to pull it out. Something like the pulley system. You can use these kinds of technique to avoid the large bone removal. Localization is important, whether it's buccal or palatal. We know the slop technique, which has been present by taking two radiographs in different directions, same side lingual and opposite side buccal, that is slop. But now CBCT is very convenient. It gives you an idea whether it's buccal. If you don't have a CBCT, you take an OPG. We have developed a software in our department, especially by one of our senior lecturers. It is available in Android. It will be in the market in a couple of months. It has been accepted, where you can just put the scan the radiograph into the software. The software, we have put three kinds of evaluation principle. One is our own technique, and two different comparative technique, which will design and tell you the position of the canine, whether it is the result with this is a screenshot, something like this. From the evaluation, here the tooth is buccal. It gives you buccal. Okay. And this is another technique of once after, if you have a CBCT, you have designed it. Now, when you open a flap, it is very difficult to again identify the tooth, where sometimes you will see like this and you don't know where to remove bone. So you can have a 3D stent, something like this, where the exact area of tooth is marked. And then you keep the stent there intraoperatively and just remove bone around, and the tooth will be exposed and you can remove the tooth out. This is another good technique. Next, cyst. Most of the cysts, the frequency of cyst has been reduced because of the excellent skills of our endodontists, because they started healing tooths it's very good. So sizes of less than maybe a couple of centimeters can be done automatically without surgical intervention. It is very good for the patient. But what if you get a large cyst with multiple tooth involvement, a chronic case? Then again, you have to enucleate. Along, of course, endodontic therapy has to be done. Now, raising a good flap, the key is to plan the incision away from the cyst is present here, one tooth or two tooth away from the tooth. Give a releasing incision, raise a flap, start raising from here. Don't go into the cystic area. Raise from the sides, go deep down to the bone, go around the tooth, expose the bone around the tooth, make sure the cyst is something like this. Now you see the lots of a little bit of periosteum is attached to the mucosa. Take a gauze, wipe it clean, wipe it, and all the periosteum will go off, and the cyst cavity of the cyst lining will be exposed beautifully. And then you can just scoop it out like any other cystic lesion. That is a basic key. And probably root end therapy can be done if your endodontist prefers. Closure. Closure, this is a sling suture. That is what we call, I don't know what the periodontist calls it. The sling suture. We are not actually taking a bite in the palate. I'm taking a bite only in the buccal. I take a bite in the buccal, bring it around the tooth, take a bite again in the buccal and bring it around and tie it here. You can see there no bite is taken. So only alternately bite is taken. Here, see, here the bite is taken, but palatally is not bite. The knot lies here. One suture, two knots. It's a good kind of suturing technique. Some common postoperative complications encountered are pain management. We are all familiar with pain management. Intraoperative pain management, good technique. good blocks, good infiltration, good choice of local anesthetic can avoid all the intraoperative techniques. Post-operative, paracetamol, diclofenac, a lot of drugs are in the market. In diclofenac, paracetamol combinations, I feel is very effective for most of the cases. Nowadays, diclofenac patches are available. The patient is resistant or has got some gastric irritation in taking tablets. You can try this diclofenac patches, which can be kept, and it is a 24 hours. So you take or put one patch, it is 24 hours, sustained release, and quite effective. There are local or Ayurvedic products also. This is something called a pineapple extract, which I came across recently, and we have been trying this out. Well, the results are not predictable right now, probably, but effect is good. Effect is good. And the dexamethasone injection will reduce swelling. If you are not familiar with the intravenous or intramuscular injection, don't worry. You can give it somewhere in this side, intramucosal. Submucosal injections of dexamethasone or methylprednisolone had been advocated or supported by literature. So this is the standard injection technique. Or you can give it somewhere in the, where you give a block into the middle pterygoid muscle or the masseter muscle also. This will reduce the postoperative edema and swelling. This, no excuse for this, never let it happen. This is iatrogenic because of your heavy retraction, use of wrong instruments, use of your burr causing burning, lacerations. This should be avoided. Hematoma, don't worry. These kinds of hematoma is usually seen in especially elderly patients with lot of subcutaneous fat and loose tissues, and when you do multiple extractions. There will be a kind of bleed which goes into the subcutaneous area. You don't have to worry about this. Give ice, make sure that it doesn't expand further. If it is subcutaneous, give ice applications and have a good antibiotic coverage to prevent the hematoma getting infected. Lacerations, this tells you the importance of having good suction tips of good instruments. Earlier I showed you some bad suction tips where the metal tip has been exposed and pointed. So when the assistant is using these kinds of suction tips, it causes tear of the mucosa here, and in fact you can see the lingual nerve very close and being exposed. We are lucky enough not to have it cut. Ora fistula is less common nowadays because of good extraction techniques, but if it occurs, nothing to worry. Again, like I said, canine exposure, sustained ejaculation, same kinds of good, raise a good flap involving surrounding the fistula, expose the fistula, if possible, especially maxilla here, this posterior region, you can see the buccal fat protruding out most of the time. And you can actually pack the maxillary sinus with buccal fat and then close the mucosa over it. Necrosis, earlier I mentioned, it can be due to medical related or unknown etiologies. Well, this is a case of a traumatic necrosis. A patient had a history of trauma and is an avascular necrosis of the sockets. And probably you will have to do a debridement and resuturing. Some heal. These kinds might heal, but it is always better to produce fresh bleeding points. Remove all the dead pieces of bone, and it should heal. And if possible, give a good coverage. Liver clot in medically compromised or patients on anticoagulant or antiplatelet therapy, we encounter this very often. Nothing to worry. If it is enlarges, give a local anesthesia, curate it off, remove all the clot, produce fresh bleeding, clear the socket, fill it with a socket material, with a hemostatic material or something, and suture it. It will produce good healing. Hemorrhage, it's a surgeon, not only for a surgeon, for all practitioners' nightmare. There are a lot of hemostatic materials available in the market. The good ones, the trinostat or tranexamic acid is available as ampules, as tablets, in 250 milligrams tablets are there for hemophilia, or not for patients on anticoagulants or antiplatelet therapy, but for hemophilic or any other bleeding disorders, you can give this on a tablet form or an injection form, or even you can apply it locally. Ferric sulfate retraction paste, a very good one. I have experienced this, very useful, especially for palatal bleed, where you have done an excision or incision and the palatal mucosa is bleeding. You just apply this, immediately the blood clots. I have seen that, I have experienced that. So you can try using that even in sockets also. So a socket like this with bleeding, the first thing is to identify whether it's a soft tissue or a bony bleed. There are two techniques. Clear the socket, see the bare bone. Look into the socket. If it is welling up, that means the bone. It is bleeding from the bone and it is coming from the bottom. If the walls are getting soaked first and then it is welling up, that means it's coming from the surrounding tissues. Surrounding tissues, give a good suture if it is coming from the bone, place some hemostatic material like Surgicel, gel form, Sap gel. Earlier I was talking about the other materials also. Okay, so you have a Surgicel, cut into a small piece, place it into the socket, bleeding stops, close it up. Some bleeding, something like this, place alveoli, you can see the clot formation present there. And you can give also, additionally, you can give, here a matter suture is given, but you can give a interrupted cross suturing also. Bone bleed, bone wax, take a piece of bone wax, take it in the back of a scoop or a periosteal elevator, apply to the bleeding area, paste it off, and the bleeding should stop. Or the best thing is, if you have an electrocautery or cauterizing machine, it's not very expensive. You know, you have different kinds of electrocautery machines available nowadays, and you can have this, any kind of bleeding can be stopped confidently. So this is how you use a electrocautery. I have a small demo for that. If it is a bone bleed, what you do is apply the cautery in the bone areas, and you can control the bony bleed if it is a socket bleed. What if it is an artery or tissue? If it is a tissue bleed, what you do is to hold the tissue with your tissue forceps or some convenient twister, and then just touch it. You see, if you watch carefully, you can see the blood getting clotted. You can see the white line passing out. That's blood immediately getting clotted all along the vessel. So have a cautery, any kind of bleed can be solved. Now the next question is to retain the remaining root or not. Well, some roots, if it is in anatomically dangerous area, or if it is close to the nerve, it is close to the maxillary sinus, and if removal will cause complications, it's better to leave it. And later on, if it gets infected, we can remove it. And socket shield technique is one best example of retaining the root. Dry socket. The incidence of dry socket in our department is much less, because we also have done a study on more than 1,000 cases and without antibiotics. We haven't found out any dry socket because if we use proper sterilized techniques. This is applicable for non-medical compromised patients. Medically compromised, you might encounter a problem. You have to give prophylactic antibiotics also. And what you get a dry socket? Well, zinc oxide back, that relieves pain, but it's an obtundant. It has got an obtundant effect. But eugenol, it interferes with the healing. Healing is delayed. So I wouldn't prefer this. Albuterol is much effective, though it has got zinc oxide along with it. It doesn't have zinc oxide. It's a combination of iodoform and para-aminobenzoate. So this is much effective, and it produces a socket filling material. So curate it, produce fresh bone, remove all the infected tissues, have a good antibiotic coverage, and you pack it with albuterol. It is available in the local market also. It produces good healing. Tuberosity fracture, I've already mentioned how to manage. Trismus is another complication. Find out the kind of trismus. Post-extraction trismus, the best way is muscle spasm. It's due to muscle spasm. Have some equipment like this, or the Eustace mouth gag, or the Ferguson mouth gag. Put it and slowly spring-like action. You do physiotherapy. You make the patient open the mouth in small increments in a gradually, in 1 or 2 days, you can achieve a good mouth opening. If you want to send the patient out, advise the patient with ice cream stick, that is the best. Allow, have a couple of sticks there, then slowly keep it in the posterior area, slowly add on the sticks, and maybe 1 or 2 sticks a day. And in 5 days, tell them to add at least 10 sticks and bring back. The mouth opening will be more than 30 or 35 mm. So that is the best way to relieve trismus. Now we all know medicine is science of uncertainty. You know, whatever you do, you practice, things might turn different. There are a lot of other diagnostic dilemmas also. So, decision making is still controversial. For example, biopsy. Biopsy, you don't know. You get a lesion like this. Can I do an excision biopsy or an incision biopsy? Well, that decision has to be on the treating doctor or the treating person. You feel this doesn't look malignant. It looks something like a pre-malignant lesion or it's a benign lesion. Go with an excision biopsy because it looks small. You can get away with an excision of the biopsy with a safe margin. Now, always one point which I would like to stress when you do a biopsy is you always tag the tissues. There have been literatures also supporting that. Tag the tissue so that the pathologist will have an orientation which is the anterior, which is the posterior. Otherwise, he will have a confusion which is the anterior, posterior, which is the surface, which is the deeper tissue. Always tag, orient, and have a piece of paper marking it something like. Just tagging alone is not enough. You have to mention where you have tagged or which areas you have tagged. Methylene blue has been used. Toluidine blue was the ideal one to detect carcinoma or metaplastic cells. But considering its toxic effects, methylene blue is being widely used nowadays. It's got more affinity towards the active nucleic acid. So cells which are in a different form or metastatic cells will have more affinity, and you can actually mark the malignant cells and you can do a safe margin of excision. So this also probably you can have in daily practice. Large lesions, of course, nothing can be done. You have to go for excision. Lesions of the tongue may not be cancer always. You sometimes get this where you see a small swelling like this, need not be a mucosal cyst. Identify the lesion, go for an excision. The funniest thing is that never do this. Surgeons have a tendency to explore, but the pathologists hate this. When I got a lesion, which was unknown, I went in for an excision biopsy. I found out that there's a hard substance inside. I just wanted to go inside and see. And astonishingly, I saw a small, well-rounded. The report came as a neurofibroma, but I never seen a lesion like this, fully exposed. Don't do that. Then I came across a lesion. I thought it was a neurofibroma. I again did an excision, but unfortunately I couldn't get any tissue. It was a different kind of lesion, more of a fibromatic lesion. So nothing, no wonder in that. Palate, again, similar lesions are there. You think it's a neurofibroma? No. Palate, always keep in mind, minor salivary glands. Minor salivary glands, you have to think it will be a salivary gland lesion. Or it could be any infection from the tooth. It could be an abscess. It could be some root still pointing up. Here it was we ruled out the presence of any root and we went in for an excision biopsy and it was a minor salivary gland. Large lesions, you can mark it out the lesion, excise. And what you do with this raw area, you cannot suture it. This is very useful. Have a tincture benzoin gauze pack and suture it and leave it there for 5 days. You can see the tissue underneath granulating. You don't have to give a suture or you don't have to give a graft. You can leave it raw. And the gland, as I said, you can see the saliva or the sticky nature of the excised specimen. If you note that the saliva or mucus coming. Lesions like this looks notorious, looks carcinogenic, or looks pyogenic granuloma. So since the dilemma was there, we went in for an incisional biopsy. Now the dilemma is where to take an instrument. It's easy to take a biopsy here. No, it will not enough. You have to have a normal mucosa. But look at this mucosa. It's slightly leukoplaque in nature. So I went in for a normal mucosa somewhere around this area and took a biopsy, including normal mucosa and the tissue. And it was proven to be a squamous cell carcinoma when we had to go for a maxillectomy and reconstruction. Thanks to our prosthodontic department to give a good obturator which produces very less cosmetic deformity into the patient and a good functional result also. Sometimes you get unusual lesions like this. Probably you should think of basal cell carcinoma, very notorious, and go for a complete excision and have a regular follow-up to avoid recurrence. Space infections, controversial, misdiagnosed, always have a tendency to send it to some hospitals. No, don't send all patients to the hospitals. Manage, some of the patients can be managed. First thing is to give an intravenous antibiotic or not, and how to differentiate cellulitis. Spaces like this, start in immediately intravenous antibiotics and drain the area. This is a bilateral spread of infections in Ludwig's angina. It will cause airway obstruction and you have to intervene. It's an emergency procedure. Cellulitis, I wouldn't go for an incision and drainage if the patient is not under, because you're not going to get pus. But some school of thought says that it will relieve the space and prevent the abscess formation. But another literature says that it can cause septicemia also when you put a surgical incision in a cellulitis state. So under antibiotic coverage, probably you can give a incision and drainage. Identify the space, whether it is a buccal space, submandibular space. This is more of a buccal space. This is more of a not a buccal space. This is more of a submandibular space, and then you should know where to incise. The conventional technique is a Hilton method. You use 11 blade, put a stab incision. I prefer a 15 blade, or most of the surgeons prefer. And the angulation blade is something like this, not stab. Put a nice incision. Layer by layer, you deepen it till you get pus. Go, take a mosquito forceps or an artery forceps. Open it up, open the tissues like this, and then bring it down till you get active pus. And surgeons are very fond of this finger dissection technique. Try not to do that. And once the pus is drained, have some betadine or an antimicrobial irrigation done, and then you can, once possible, you can keep a drain. How do you fix the drain? It's quite easy. Place the place the drain. Take a bite around the drain, something like this. Maybe you can take bite along or through the drain and into the skin and knot it down. It stays there. It should not slip off. Spaces like this, we don't know the etiology, whether it is from groups have multiple tooth problems. It can be it's called the lateral pharyngeal space. Very dangerous. Airway problem can arise immediately. So this has to be intervened. But without surgical intervention, maybe by manipulation for taking photographs, having suction examination, somehow this broke and pus started coming out. And we put the patient on IV antibiotics. Luckily, we had also taken the consultation of we are referred to an ENT surgeon who in fact didn't have to do anything, because all the pus were, by that time, was drained spontaneously out. And after antibiotics, after 10 days, the patient came back with complete recovery. Have you ever seen a lesion like this? Very rare, very rare, very rare. Even I was wondering. Then I started cleaning up. This had come to our department a couple of years back. And we started cleaning up, and I found out this kind of material. It's called the myiasis. Myiasis is the housefly laying eggs and the larvae coming out. It's usually seen in debilitated patients. And you extract the tooth, curate it out, be patient and pick out all the larvae and clean the whole thing, and it should heal. Cellulitis, earlier I said, bacteremia should be prevented. And sometimes you get fistulas like this, which may not spontaneously. So excise the fistula and primary closure. All fistulas need not be restricted. These kinds of fistula, submandibular infection subsided, but the fistula remained, and we had to go in for an excision of this fistula. These kind of fistula, we planned for an excision, but the third stage, maybe after 1 week, we called the patient for review. We saw that the fistula was healing. We waited for another couple of days. It healed much better. And after 10 or 52 weeks, they heal completely. So all fistulas need not be excised. And all swellings are not abscess. So when you diagnose it, have a proper differential diagnosis, go for necessary investigations, even don't hesitate in going for a CT scan and other things. Lesions like this, typical, you think of mucosal, go for incision, put a nice incision, expose the mucosal, like I showed you. This is how you should expose a mucosal. It's a mucosal present in the tongue. You dissect, you go away from the tissue, separate the muscle fibers like this, and expose the glistening layer out. See, be patient, expose all the layer, and you can see the mucosal popping out, or most of the cystic lesions in the soft tissue popping out. Something like this. Very rare to get a lesion like this when you put it in formalin. And again, you get a lesion like this, you think it's a mucosal, definitely not, be incised, and it was a rare condition called a lipoma, a fat deposit seen there. So think of unusual lesions also when you see. So rule out these unusual lesions before going for a excision biopsy. I told you all swellings are not abscess, looks like a beautiful vestibular abscess. Radiographs were taken, sort of cystic lesion, and yes, pus was there, but looked like a pus, but it was an infected cyst. It was a keratocyst, whereas we did an incisional biopsy and led to the excisional biopsy, and final treatment was done, curettage and chemical cauterization. Floor of mouth, ranula. No, it is not a ranula. Carefully examine. Put your hand, palpate, inspection, palpation, percussion. That's the first thing we learn in third year general surgery. Have it in mind. Palpate, you see some hard object. It was a calculi. So you remove the submandibular calculi. And all calculi you need not inside. This looks like a small pus or pustule. Look at the area. It's an anatomical area of the parotid duct. Palpate, I could feel a hard stone. Push it out, and sometimes by pushing it out itself, it cannot come out through the socket if it's small. Now put a small incision and then try to milk it out from the gland, and it will pop out. Large stones have to be incised. This is one technique which you all have to practice. First, take a bite on the duct and secure it, so that when you put an incision and when you manipulate this duct doesn't go or doesn't get displaced posteriorly into the deeper part of the gland. So this can prevent that, and you can easily incise it and remove the stone. But sometimes once it is located inside the gland, you will have to do a submandibular gland excision. It is not possible to take the stone out from the gland. Maxillary vestibular swellings, again, you think of osteoma. Sometimes you encounter ameloblastoma. You have to always keep in mind and has to be excised. So incisional biopsy and then go for probably an excision has to be done. Okay. This is a case. Can you make out anything in this radiograph? You look carefully in the left side maxillary region. You can see a tooth impacted on an unerupted tooth form. Well, we thought it was a tooth. We tried to expose it, but unfortunately, it was not a tooth. It was an odontoid-like structure, or it was a bony-like structure. The biopsy report came as an odontoid. So expect the unusual presentations also. Carefully observe this. It looks like a gingival hyperplasia, but just see this video. Can you see? Can you see that the pulsatile nature? You look carefully in this area. Most of you will be able to appreciate the pulsation of the lesion. It's a highly vascular. So inspection, palpation, I told you. Inspection, inspect for all these findings. Don't just jump into conclusion. See, rule out hematological lesions or vascular lesions. CT scan was taken. There are beautiful radiographs which we can take. You talk to the radiologist, he'll give you good images with CT. You can play around a lot. You can see images like this, giving you an idea of the whole vascular lesion. And that was later on excised. Of course, you need a general anesthesia for this. And sometimes the X-rays fool you. You see a big cystic lesion. There is a periapical cyst. You open it up, you see nothing. It's a traumatic bone cyst. The X-ray or the bone has fooled you. It's just a bony cavity. To treat or not is a different question. And again, you get lesions like this. You open it up, you see only the cancellous bone. You don't see any pathology in there. It's maybe a hyperreaction of the bone to certain forces. And osteomas are common. Get good radiographs that will give you clear evidence of lesions like this. So any swelling, investigate properly with good radiographs. Because lesions like this mimic a vestibular, a space infection, but you get an MRI angio and you have a vascular lesion. It is a submandibular gland hemangioma. And you also get a buccal space-like swelling. Evaluate, you get a well-defined submesenteric space lesion, which is highly vascular, and again there is a AV malformation. Now, as I said, the forewarned is forearmed. Now, all surgeries are not very successful. If you remember this, I showed this fistula closure. Yes, I closed this fistula, but patient came back again. He had a chronic infection. We had removed the tooth, but the infection was progressing, and there was a pathological fracture. We went in for the exploration. We removed all the necrotic bone. The bony bridge was reconstructed using a reconstructive blade. Everything looked fine until, even on radiographs, it looks fine. Until 3 months later, the patient reported back with again infections with multiple fistula. Again, we removed the adjacent teeth, thinking that was a cause. So the whole area became medullus, was reconstructed, and but still the infection did not subside. Patient reported with fistula again. We had to go. These are some of the cases of unknown etiology where it causes osteonecrosis. So like I said earlier, it's not only bisphosphonates induced osteonecrosis. There are a lot of unknown etiology, unknown causes for osteonecrosis. We couldn't literally identify the cause of necrosis of this patient. And finally, the plates were infected and the plates were removed, and we had to close the bone. So multiple surgery, long-term follow-up. The surgeon has, you cannot run away from a complication. We don't know whether it's a complication, or you'll be seeing a lot of cases like this. I have come across various cases of unknown etiology and osteonecrosis of jaws and with pathological factors which we have treated. Similarly, this is the case, but the patient is still alive with a hemimandibulectomy. We had done a hemimandibulectomy and reconstruction has been done. And sometimes you get facial swellings like this. Yes, you take a radiograph, unusual presentation of a cystic lesion in the zygoma. Well, it is an aneurysmal, very rare case of aneurysmal bone cyst of the zygoma. Zygomatic arch also. And sometimes we get lesions like this. This came back 1 year back with a lesion of the maxilla. Multiple intraoral biopsy was done in our department, but the pathologists were unsure of the report. They were always in a dilemma. So repeated biopsies were advised. And finally, after 2-3 biopsy, incisional biopsy, we went in for an exploratory biopsy. Exploratory biopsy, we did it in our hospital here. We opened up the area, we took the biopsy for the sinus. We literally were unable to take off the whole lesion because the lesion was extending up to the infratemporal fossa with the loss of the bone. And later, the report came as sinonasal papilloma. And we had to take back the patient again because sinonasal or inverted papilloma behaves something like a squamous cell carcinoma. So we had to take back the patient again and do a hemimaxillectomy procedure. A common case of submucous fibrosis, yes, we thought we could achieve good result. We went in for a laser excision or laser fibrotomy by releasing the fibers. Laser is a very good tool in doing such procedures, especially fibrotomy, vestibuloplasty, and removing such lesions. So there was a suspicious area here. So we took a small tissue for biopsy. I would say that most of the pathologists will disagree with me when I said that I took a laser incisional biopsy. Well, I took it from with a safe margin. I didn't want the margins to be clear. It was an incisional biopsy, and the biopsy reported as squamous cell carcinoma. So recent studies have shown that submucous fibrosis have a potential for malignancy. There can be a area of malignant component. So always subject the fibrotic bands for histopathological examination, which was not a common practice earlier. So you see a submucous fibrosis, educate the patient of the future carcinoma or the conversion into squamous cell carcinoma. We had to take the patient back again. We did a wide excision and reconstructed with a skin graft. Similar case, if I remember, around 8 years back, 8 to 10 years back, this patient came with a swelling in the right mandible. The cyst was there. Incisional biopsy proved as aminoblastoma. We did a hemimandibulectomy. Here in our call, we did a hemimandibulectomy, and I reconstructed it with a reconstruction plate. The options of microvascular surgery was given at that time to the patient, and since we were all not very familiar with the microvascular procedure, the patient also was not ready for that. So we went in for a reconstruction plate. Everything was fine until 3 years later, the patient reported back with an implant failure. The reconstruction plate got fractured. Then we went in for a reconstruction with a free fibula flap. So keep in mind, 3 years back, you gave a result. Follow up the patient, one for recurrence and for implant failure. You can't leave the patient like this. You have to treat the patient. Think of our possibility. Here, we were able to give a free fibula graft, microvascular reconstruction for the patient. Basal cell carcinoma, I showed you a small lesion which we excise. This is a case which I have been seeing for 10 years, I would say, around 10 years. And see, the patient reported with previous history of surgery of basal cell carcinoma and reconstruction with a multiple recurrence. We went in, we took out, we marked the area, and we excised the whole thing. And this was the post-operative result of the patient. And later on, the patient came back after 2.5 years with a recurrence, and he gone to a different center, had an orbital acceleration. He came back to us again for rehabilitation. And thanks to our prosthetic department again, with their wonderful job, we made a stereolithographic model, and wonderful temporary prosthesis was given to the patient. Later, again, 1 year later, 2 years, if I remember, 2 or 3 years later, he came back with again a recurrence. We had to do again, remove the whole portion of the maxilla. We did not leave. We again gave him a temporary prosthesis. The patient is still under follow-up. Last 6 months, last 1 year, I lost follow-up with this patient. I don't know whether the patient had multiple recurrence. Basal cell carcinoma is a very annoying disease. You know, it doesn't. It is not. It may be a terminal disease, but a very, very slow eating disease. You know, I've been seeing this patient suffering for the past 8 years. You know, whatever the changes or whatever we do, we should look for the welfare of the patient. And a surgeon alone cannot never strive. He needs the support of all the disciplines of not only dentistry, but of the medical field. And, you know, we should work along for the betterment of the patient and for ourselves. And knowledge and reading alone is not alone enough. Surgical techniques and procedures, update yourself and improve, practice, have some ethics in you and humanitarian consideration. Don't run away from complications. You know, complications are inevitable. You have to find out, get opinion, learn from each case, treat them with the help of other specialties if required. Never hesitate is getting help. Read, update your knowledge, train yourself with different courses, attend newer courses, adopt new technologies and new techniques and multidisciplinary approaches. Now, thought somebody has said, thought is the wind, knowledge the sail, and mankind is the vessel. So let us actually join hands and start working together as a single specialty rather than having individual specialties with a common clinical sense and skill so that we can end up demystifying all our challenges and we can give our patients or our patients can be the winners and can so would be. And thanks to my department, a wonderful support of all my staffs, PGs of the surgery department. And thank you and a happy new year 2021. And probably this will be the last CD program of the 2020. Thank you.
So I would like to thank Dr. Suresh Kumar LK for providing a wonderful insight. And I definitely speak from my heart that it has been definitely beneficial to a specialist as well as a general practitioner. Take it apart, let it be a UG student as well as a PG student. There are a lot of tips I think that will prove mighty useful in their private practice. So let me invite our chairman, Dr. P.S. Taha, to share a few words with the participants as well as the resource person of the day.
Dr. Suraj, very amazing presentation. I think one of the best, webinars that we have conducted in 2020. Being a periodontist, I was more than a periodontist, I was a general practitioner. And, since of course 3-4 years, I'm not doing much practice, but it reminded me of my early days of doing, surgical procedures, including extractions or impactions and all. And I have developed my own techniques of doing surgical removal of impactions. But now I realize that I was doing the right thing because I saw the incisions and the procedures and the guttering technique and all, which, without anybody training me, I developed my own method because there is no way I have to do it. So that is way, but now anyway, today you made my day. I have been very happy that, this is one of the best presentation and I could get a very deep insight into the surgical procedures. Anyway, thanks to all the participants, Dr. Varghese, Dr. Rajesh Pillai, and everybody who has participated, and really great. And also, I would like to congratulate all the staff and the PG students of your department for getting the, the best, prizes for the online competitions, getting, I think you have been given, your students have been, you have got about 10,000 rupees as rewards for the best paper for online presentations. And I congratulate each and every student for that. And I have also decided to give each of them the same amount from the PMS college also. And congratulations, Dr. Suraj Kumar for this presentation. And thank you everyone for being present and attending this lecture. And wish you all a happy 2021. Thank you.
Thank you, sir.
Dr. Varghese Mani, sir, anything to add upon, sir?
Can you hear me now?
Sir? Yes, yes.
Well, it was an excellent lecture, Suraj.
Thank you, sir.
You have covered almost all the minor surgery and even the many of the major surgery procedures as well. It was a learning experience for me as well, Suraj.
Thank you, sir.
From my juniors rather, and from my students as well. That is what I feel, when you become a professor and when you have got PG students, what you actually do is that, you are learning from your PGs. That is what is happening. Now, there is no need to go for all all the papers and all those things. You just to scan through it, see the what topic is being discussed in each paper, and ask your students to give a presentation of that, and you learn it. That is what I consider as being a postgraduate teacher. In this case, I think that you have done an extensive research on this, and you have given an excellent lecture. What I'm saying that there is a learning experience for me also. Thank you, Suresh.
Thank you. Thank you so much, sir.
So there are no questions at presently on the chat box. I would like to congratulate Dr. Suraj for the wonderful lecture again, and wishing all the participants a very, very happy and fruitful 2021. Thank you very much, and good night.
Thank you, Dr. Rajesh. Is it because that nobody understood anything that there are no questions, or people have understood everything?
It's not like that. You made it so simple. I think even a non-specialist oral surgeon like me also could follow many of the terminologies like you, and we could imbibe a lot of new things into our private practice also with your lecture.
Anyway, thank you, Manisa, for even after a short notice, you are able to come and grace this occasion. I'm very honored to have you as my moderator here in for my lecture.
Thank you, Suraj.
And thank you, Sardar sir, also. Thank you, sir.